further into it. I'm not going to teach you hemorrhage on MR because we have done it. And in the CT, in the trauma world, usually it is CT, except for diffuse axonal injury, in which you might like to use SWI sequence, and we will see a few cases. Okay, just my question is a lead question. How will you tackle this? How will you describe it? Can I hear your description, please?
Yeah, there is
trauma.
So it's an axial CT slice non-contrast with areas of hyperdensity in the right parietal region with surrounding edema and cervical effacement. There's also effacement of the lateral ventricles on the right side with some midline shift towards the left. So these are in keeping with intraparenchymal hematomas or hemorrhage with edema around it and signs of pressure effect on the ventricular system with midline shift. I would like to scroll through the rest of the image. I would also like to see the bone window as well. Just
so what is your conclusion? What is your diagnosis? Just in one word or two words.
So it's an intraventricular hematoma and intraparenchymal hematoma. There's also a suggestion of some isodense subdural as well on the right side.
That is just an artifact. So you are calling it an intraparenchymal hematoma, correct?
Yeah.
Okay, so that is the point. Don't use this word. The point is you have to be very, this concept here, primary head injury can be divided into primary, secondary, and delayed effects. Primary is at the time of injury. There are only two types of parenchymal injuries which can happen. One is contusion, and second is diffuse axonal injury. With that, there can be hemorrhages, as in extradural, subdural, subarachnoid. There can be fractures also. So this is a contusion, and contusion, by definition, think like a bruise. Bruise is when the surface, if you are hit, you are playing cricket and you are hit on your elbow by a cricket ball, you will get a bruise there. So on the skin surface. So the surface of the skin is the cortex. When the cortex hits the skull, usually there are particular sites, and for example, base of skull, etc. Frontal lobes, because undulated appearance of the skull base is there. So contusion will occur there. So by definition, part of the cortex has to be involved. Now, contusions can be two types. One is non-hemorrhagic, which is low density, and then is hemorrhagic, and which is, of course, punctate, high density will be there. So if you see here, this is what is happening, but if you see carefully, it goes all the way to the cortex. So call it a contusion. Look at these secondary effects. Cerebral edema and ischemia, this is asked in the exam, and I'll come back to this. Herniations are important. Embolic complications, including arterial dissection, this is important. And long-term effects, particularly, let's say, leptomeningeal cyst, this has come in the exam. I've also shown you arteriovenous fistula, dural AV fistulas before. This and this I'm not going to show you. Leptomeningeal cyst I have shown you, but maybe we will just revise it. I will come to this concept, and I will also come to this concept. Diffuse axonal injury is very, very important. So what is happening here in the frontal lobes? Just give me the diagnosis.
So there are bilateral frontal lobe contusions.
Excellent. So this is the type of contusion where you can imagine that it has, the gyri, they have hit the base of the skull, and then there is low density, and then there is punctate high density. So this is contusion. Now, Please remember the concept in trauma world. All of the lesions, may it be contusion, may it be diffuse axonal injury, may it be extradural, subdural, there it can enlarge. It can enlarge. It can become bigger. So, uh, as a radiologist, key thing to remember is that if you are on call and somebody has asked for a scan at 2 o'clock and you report this scan, you say that there is contusion. 6 o'clock in the morning, the patient has deteriorated neurologically speaking, and the clinician wants a rescan. Don't refuse it. Do it, because things might have changed. So remember this concept. This patient, after 12 hours, this was the subcortical contusion, subfrontal, and then it has become such large parenchymal hematoma goes into the ventricle. Please also remember that this case has come in the exam or similar case quite a few times. They will show you subtle frontal contusions because of anatomy, because it is just to the next to the base of skull. There might be artifacts there. It might be a subtle finding, and you are going to miss it.
Yeah, there is
On
here.
this is different, and this is different. So, what is there something in the subarachnoid space on this scan?
There is a locule of gas on the, yeah.
How will you confirm this?
I would do a bone window, and then we'll check for the fracture for pneumocephaly.
My question is more basic than that. So you are absolutely right. You will go for bone window. You will go for an associated fracture. If you see here, there is a hypodensity. What is this hypodensity?
It's most likely air.
How can you confirm this? Okay, what is this hypodensity?
It's again most likely air, but could be again fat can have the same kind of appearance. We'll have to go through.
Excellent, excellent. So this is a ruptured dermoid, by the way, which is an exam case, and this is pneumocephalus. And the key thing is that you have to ask for what?
Hounsfield unit.
Excellent. So ask for Hounsfield unit, and this will happen in the exam. That even if you pick up here, you will say that I would like to confirm it. Of course, when there is history of trauma, it is more likely. What about a patient having a dermoid and a ruptured dermoid with secondary trauma? That can also happen. So this skill I am trying to emphasize: ask for Hounsfield unit, ask for hand. This was ruptured dermoid. Fat will have anywhere density between about -50 to -100. This will be minus few hundreds, like 600, 700. Pneumocephalus, I'm just showing you, all of you know what is pneumocephalus. Pneumocephalus sometimes can cause pressure effects also. This case, if you see here, there is a lot of base of skull fractures, and there is so much air that it is causing a bit of pressure effects here. And look at the word tension pneumocephalus. You have seen tension pneumothorax, but this is the pneumocephalus. Okay, a bit of anatomy, and this anatomy is a recap. All of you, who are sitting the exam, for you, all of you know this, but just a recap. That what are the critical points vis-a-vis the exam of anatomy, which will be very helpful. Now, this is the lateral ventricle. The lateral ventricle has the frontal horn, body, and the trigone. This is the temporal horn, and this is the occipital horn. Please remember that the trigone is quite a substantial structure in a craniocaudal dimension. So if the slice is going like this, this is the level of the body. So posterior to the body is going to be the trigone. Look here, frontal horn, body, and trigone. On the other hand, if the slice is going here, so this is the third ventricle, this is the occipital horn, again trigone is there. So look here, this is the third ventricle, trigone is here. Occipital horn is here. Now, usually occipital horns are not well seen unless patient is advanced age, as in slightly atrophic type of brain. But they have shown cases in the exam where what has happened, because occipital horn is dependent, the patient is lying down and there might be intraventricular hemorrhage sitting in the occipital horn. And the question is, where is this hemorrhage? And that's a very well-defined hemorrhage. And the answer is, this is in the occipital horn, instead of saying that this is in the parenchyma. So this was about this. Now, coming back to the anatomy, we know that from the lateral ventricle, it goes through the foramen of Monro into the third ventricle, and then to the, the aqueduct and the fourth ventricle. Now, anatomy-wise, few things for the trauma world are important. Look at this. This is the level of pons, and this is the level of midbrain. And pons has got this belly. I call it the fat man. And this is the midbrain, which is the Mickey Mouse. So this appears like a Mickey Mouse. Now here, this is the cerebellopontine angle cistern here, and this one. This cistern is important for you vis-a-vis herniation. You will see when there is transtentorial herniation, one of the things which will happen is that the cerebellopontine angle cistern on the ipsilateral side will become widened as compared to the contralateral side. So you have to, when you in the exam, there can be marks for the description, because the examiner have to discriminate between somebody who will get 6 marks and pass, somebody who will get 6.5 or 7 or 8 marks. So descriptions are important. They are seeing what you are picking up. Now, just superior to this level is a very important level vis-a-vis trauma or whatever. This is the suprasellar cistern. So this is the pons. This is the posterior clinoid process, anterior clinoid process. Just superior to that, I am just superior to the level of the pituitary fossa. Here, there is pons. Interpeduncular cistern. Interpeduncular cistern is an exam cistern. They will show you subarachnoid hemorrhage sitting here. Around this, anatomy is very critical. This is the ambient cistern. This is the quadrigeminal plate cistern. This thing is the uncus. What is uncus? Uncus is the medial-most portion of the temporal lobe. And this is the structure which, dips into the incisura, into the hiatus to cause transtentorial herniation. When it slips inside, it will compress this, and this will be projected, displaced to the contralateral side. On the other hand, it is going to encroach on this cistern, which is this cistern. This is the suprasellar cistern. So when there is transtentorial herniation, initially suprasellar cistern is going to be partially effaced. And then when there is blatant, full-blown transtentorial herniation, the suprasellar cistern is going to completely vanish. So these are important, anatomy features for trauma. Now, look here, intraparenchymal hematoma, intraparenchymal, and it has gone into the occipital horns. So this is the trigone. It has gone into the occipital horn here. 3 different patients, occipital horn. This one is in the ventricles, but this is at the level of trigone. This is the body. Okay, candidate 6, trauma. What are your findings?
I can see there is high density within the subarachnoid spaces on the left cerebrum towards the vertex in the second last axial slice and the last one as well. There's also some contusion in the inferior frontal, left inferior frontal lobe.
Excellent. Well done. So the idea here was to pick up 2 different findings. And so this is a subtle contusion. And this one is a traumatic subarachnoid hemorrhage. Please remember that trauma is the most common cause of subarachnoid hemorrhage. And so this is two things which have, and the bottom line is that in the exam always go till the vertex. So subarachnoid hemorrhage here might be just on one slice higher in the vertex. Look here, subarachnoid hemorrhage in the interphalangeal cistern. Look here in the interphalangeal cistern. Any subarachnoid hemorrhage?
Just going through. There is some high density, especially on the right side, parietal occipital junction.
So this is the Sylvian fissure, right?
Yeah, there, but on the first slide as well, I think there's a bit of high density in the subarachnoid space.
Okay, fine. So basically, subarachnoid hemorrhage in the Sylvian fissure. Okay. The history of trauma in this case was about 4 days old. Is there some finding?
Yeah, there is some. Sorry, I just quickly go through.
Go to the vertex, please.
There is some subarachnoid hemorrhage on the left cerebral hemisphere towards the vertex. In the
Can
last.
you be sure that this is subarachnoid hemorrhage? Can it be anything else other than subarachnoid?
Yeah, there could be calcification in the gyral calcification, gyral fold
calcification. Look at the density.
It's not that high. Yeah, you're right.
Calcification will always be more than 80 Hounsfield unit. You see, if you see this is something like the gray matter.
It looks more like to me hemorrhage to me. Most like.
What else can it be? How are you going to tackle it in the exam? That's the basic question.
In exam, look at other sequences as well, and also.
Nothing else except for this finding, this finding, this finding, this finding. Now, if you look carefully, this is if you see this.
There's some sulcal effacement I can see here as well.
Absolutely. So there is sulcal effacement. Look at the sulcus. That sulcus is not visible here. That sulcus, there is something sitting inside, and there is all the way up. So look here versus here. Look here versus here. So there is effacement of the sulci, and there is some high density. You cannot be sure that this is subarachnoid because the density is not 56 or something, right? So. Yeah. What can it be? How are you going to tackle it? That's my question.
Do an MRI?
First thing, so what is your differential diagnosis for this finding? MR is not a bad answer, but what is your differential diagnosis? Because I'm going to ask you the same question in MR also.
Yeah, it could be some kind of tumor as well, or some mets, some.
Okay, now if you see here, this is a revision from your first basic session. This is 6 days old subarachnoid hemorrhage, which was not at all visible at that stage in the CT scan. Here on the MR, what happens is that it is bright signal within the sulci. Similarly, on the CT, what is happening? That there is some bright signal, bright density, slightly high density, but you cannot make out that this is hemorrhage. Bottom line is that when you see this finding, it can have a differential diagnosis. The differential diagnosis can be a leptomeningeal process, as in infection, carcinomatosis, can also be subarachnoid hemorrhage. So the answer is that you have to give contrast. On a CT scan, if you want to ask for MR, fine, not a bad answer. But even on MR, ultimately, if you pick it up, you have to give contrast. And when you give contrast, then you can discriminate between the two. You know, subarachnoid hemorrhage versus leptomeningeal process. And this is a flare sequence with a high signal, and on enhancement, it enhances. And this is esophageal carcinomatosis. So these cases I have shown you previously. Okay, just very basic case. What is happening here? And I want to hear the words. What is this?
So
And what is
on the left side there's acute extradural hemorrhage. On the right side there's a contusion, and there's also subarachnoid hemorrhage as well.
excellent? So subarachnoid hemorrhage can be, traumatic subarachnoid hemorrhage. That was fine. Is there a extradural hematoma on this case?
On the left side, there is some air density.
Temporal, middle cranial fossa. Is there something happening there?
Yeah, there is some anterior to the midbrain. There is some low density. No, that's
okay. You see, this extradural hematoma, which is middle cranial fossa, has come in the exam quite a few times. It's a difficult one, and that is why I'm showing you an example. If you see here, there is, and in the exam, it's easy to miss because there will be a bit of hemorrhage. Intentionally, I had not shown you this one here because it's visible, and then it is visible here on a coronal, it is visible here. Middle cranial fossa extradural hematoma is easy to miss and has come in the exam quite a few times. How are you going to tackle this or this case if you are reporting this? Classical viva question.
Yeah, in the patient one, this
is the same thing I am showing you.
Okay.
I'm showing you patient 1 and patient 2 with the same finding. My question is a viva question. You have picked it up. You are the on-call radiologist.
Yeah.
What is happening? What will you do?
I can see the blood extradural hematoma, but then there are different density blood within it. So there could be an acute bleed within the previous extradural hematoma.
Excellent. Previous extradural hematoma.
Not previous. To say acute on acute or acute on subacute kind of stuff.
Acute and acute is better way. But okay, I'll come back to this. What will you do? This is a viva question.
We'll do an angiogram here as well to see.
Okay, this is a critical thing to pick up. You see, the point is that you are an on-call radiologist. You pick up this extradural hematoma. Within an extradural hematoma, if you see this is known as a World sign, if you see this low density means that there is active bleed going on. This is how you infer it. It's not, don't confuse it with the subdural hematoma. And means active bleed means that the patient is bleeding when the patient is on the scanner. Means you don't know what will happen 10 minutes, 20 minutes down the road. What will you do? You will pick up the phone. Excellent. You will pick up the phone and tell the surgeons this is what is happening and, urgent management. So extradural hematomas can also enlarge like this case here. So at 2 o'clock, it is very, very small and then it has expanded. Yes, please. A&E, history of trauma.
So there is an acute or rather subacute kind of extradural hematoma on the right inferior frontal lobe.
Extradural hematomas are not subacute. Extradural hematomas will always be acute. Yeah,
the density looked slightly less to me than my liking, so that's what I was thinking. But
that's a very good thinking. And look at this slice. Anything comes to your mind?
There is some calcification at the periphery of it as well.
How do you explain that?
Well, it's an old collection with some infection or maybe some.
What do you think this is?
The calcification shows there's a chronic process. So.
Excuse me, have you noticed that I've shown you the next
meningioma, maybe elliptical kind of meningioma?
This is a meningioma.
Yeah.
That was a trick case.
Yeah.
It's a trick case which can come in the exam.
Yeah.
You see, this is a classical trick case where you assume things. And by the way, this is what happened in this case. This presented with, history of trauma. And the key thing is that this is a meningioma with calcifications. You start thinking, why calcification? Give contrast, and this is a meningioma. Okay.
Yeah.
This is your last case, and candidate 7 should be ready then.
So there is an acute subdural hematoma in the left occipital, in the region of left posterior fossa, abutting left cerebellar peduncle. There's also some pneumocephalus there as well. I can see the subcutaneous air locules as well. In the bone window, there is a fracture through the bone as well. So a fracture, pneumocephalus, and subdural.
What kind of hematoma is this?
I think it's no, it's I will have to reconsider because it's by lens image. Again, it's extradural hematoma, I would say. But I would scroll through. I think it looks like a.
That how can it happen?
Uh,
Etiology,
Trauma?
anatomy. No, extradural hematomas. You know what has ruptured? Extradural hematoma. What is the,
normally it's the meningeal artery.
so? What has happened here?
Shear force. This color looks a bit deformed.
Okay, I'll take over. You can mute yourself. Thank you. Well done. Now, this is a very, very good exam case, and this is what we call a extradural hematoma, which is the etiology is it's a venous extradural hematoma. Please go back to the basics. Extradural hematomas can be arterial and venous. Usually, 80 to 85% of them are, or 85 to 90% are because of medial meningeal artery rupture. But when a venous sinus is ruptured, it can cause a venous extradural hematoma. Anatomy tells you this is posterior fossa, and what the structure here is the transverse sinus. And one of the key findings here, and that is why it becomes a very, very important exam case, very good exam case, is this. This is the jugular foramen. In the jugular foramen, you can see a bubble of air. And what does it tell you? That once there was a fracture, the dural sinus tear was there, and air has gone in, and part of the air is sitting in the jugular bulb also. So this is a venous extradural hematoma. Okay, candidate 7. What is this?
It's a subdural parafalcine, posterior parafalcine subdural hematoma.
Excellent. So subdural hematomas, so favorite for the exam, subtle subdurals, and you have to understand what will happen. Subdural hematomas, they cannot cross the midline, they go along the falx, they can go along the tentorium. Now, this portion for the exam is very important because a subdural hematoma will go along the tentorium, and this is the hiatus. So the midbrain is sitting here, and it might go here, it might go along this. On an axial slice, it will become difficult to pick up. And this is what they show in the exam. So if you see here, this is dura, this is the inner lining of dura, this is the falx. And a subdural hematoma will go like this. This MR beautifully shows you what happens, that it is going along the tentorium like this, along and over the convexity, but it cannot cross the midline. So this is the MR of the same case. Now this is the type of case which comes in the exam where we can see this hematoma, and the question is, where is this hematoma? And people confuse it. Somebody will say it is in the occipital lobe, somebody will say it is in the cerebellum on an axial slice. But the key is that part of it is going along the dura. And you see, this is what I'm talking about. And this means that it is within the tentorium. So this has come in the exam so many times. Where is it? That is, they're going to grill you on an axial slice. Look at this case. And it goes along the dura here, along it, and this is an MR which tells you where it is sitting. It is sitting in the tentorium. It is sitting in the tentorium. But on an axial slide, it becomes a bit confusing. Okay. History of trauma. Is there a hematoma there?
There is a small subdural hematoma along the right parietal region, just at the region of the sylvian fissure.
Which slice? Whereas slice top row below, second row.
So I can see it better sort of in the middle image, in the first and middle image in the bottom row.
Okay. What can you do to confirm this?
I can change some windows in my back so that I can see the subdural better from the bone.
Excellent. So if you see here, have you confirmed it? Not on the same slice, but maybe, the first three slices or the top, middle, and right slice.
Yeah, it confirms an acute subdural.
Right. Actually, the teaching point here is, and this is how, those of you who don't do it in your clinical practice, you must do it. And in the exam also use it. There is a window, we call it subdural window, whatever you want to call it, subdural hematoma window or subdural window. This is used only in cases of acute trauma. Subdural hematoma can be chronic, so it's useless there. The basic concept is that in this case, what happened was that there was a subdural hematoma here. We missed it. And actually, it was visible on this window. If you see, this is known as subdural window. I'll give you the windows shortly. And there is a subtle. So what happens is the hematoma and the bone, they become conspicuous by different densities. On the regular window, it doesn't. I have seen over last few years about 4 cases like this, which became big problems. This case, what happened? He went home because we discharged him from A&E, and he was living single and became unconscious because the hematoma increased. And 3 days down the road, the classical story, the neighbors say that he is not coming out, the police barge in, and he is unconscious, brought him in, and there was a subdural. He died actually. So what are the learning points here? That this is the window. The literature tells you level 75 and window width 150 to 200. This is your choice. I usually use this level 75 and width 175. So, and you are going to otherwise miss this kind of subdural hematoma. Any hematoma here?
Yeah, again in the middle cranial fossa, I can see a right-sided fine subdural.
And do you agree that it is better visible?
Yeah.
Okay. Any hematoma?
I think there is a hematoma along the left convexity with some mild. Actually, it might be because they're so iso-intense and there's no midline shift. Could it be like a bilateral accidents hematomas? But there's definitely something along the left convexity I can mildly appreciate.
Now, this with contrast, I'm not at all asking you to give contrast to make this diagnosis, but just as a teaching point here, if you see when, subtle subdural hematoma, which is isodense to the parenchyma. So isodense has come in the exam many a times. Hypodense is easier, but isodense is more difficult. Key thing here is look at where is the gray-white matter junction. And if you see here, the gray-white matter junction is sitting here. And something is there, of course, midline shift. On the other side, you see this is the gray matter and this is the white matter. So the junction is normal. So this was only unilateral. These ones are easy, so I will just skip it, and you can see that sometimes the teaching point or the exam point is go back to the vertex. Always go to the vertex, and you in the last slice might show you subdural or acute or chronic subdural. This is just a point to remember that if you go back to the physics tells you that the basic concept on a CT scan is that acute hematoma will be 56 to 76 Hounsfield unit on CT scan. More than 80 is calcification, and less than that, gray matter and white matter, etc., have got various kinds of Hounsfield. But the but is that this depends on hemoglobin concentration, and this figure is valid for 13 grams per deciliter. And this is from literature, from rather ACR, American College of Radiology, teaching files, that they have documented a case in which the hemoglobin was 8 grams per deciliter and acute hematomas were low density. So physics tells you this can happen. How can this case present in your life? For example, there is a case in Scotland, offshore rig in Scotland, and had a head injury and had other injuries, loss of blood, but the weather was not good. They are keeping the patient alive with a lot of IV fluids. Helicopter brings it to you, maybe 12 hours down the road. Patient is still alive, but has lost a lot of hemoglobin. At presentation, it is only 8 grams. And when you do a CT scan, the hematoma might be low density. So that is the concept which you have to remember. And with that, the concept of subdural hygroma. So when there is a chronic subdural hematoma, if it is very ancient, very old, it might become like fluid density on a CT scan. On an MR, it can be fluid intensity, which can be CSF, just like CSF. So that can happen. This type of hygroma, usually you will see in old age group or in children. But if you see it in children, think about NAI. Now, another point is that subdural hygromas at times can be high in signal intensity on T1 weighted sequence, which will be confusing for you because of high, proteinaceous content, and the protein might be bright on T1 weighted sequence. Subdural hygromas can rarely, there is another mechanism of development of subdural hygroma, which is because of a defect in the arachnoid. So this is post-traumatic. So what can happen? This is a case of day 1 and day 2. And you can see that there is a subtle subdural here. There were other findings also. But on day, you repeat the scan and you can see a hygroma. And how do you explain this? That basically there was a defect or a traumatic rent in the dura. So this is another concept of the word subdural hygroma. Very rare. I've seen a few cases in my life, but it can happen. You should understand that mechanism. Okay, candidate 7. What is this?
So it looks like the patient has had previous embolization clips, and then around that there is acute hemorrhage with areas of pneumocephalus. So,
excuse me, hint A and E. Patient is very serious in coma.
So I mean, I can see a lot of pneumocephalus throughout and then there is a significant brain edema with complete effacement of the overlying sulci and some midline shift to the left and acute hemorrhage. I'm just trying to categorize the hemorrhage.
What is this? What is this? What is this? You were worried about embolization clip. There is so this is metallic density. That's the hint.
Oh, he's got a traumatic, so like a bullet injury or something like sharp injury.
So this patient, just wanted to show you because otherwise you will get confused, as you did get confused. It's very easy. Shotgun and multiple pellets and more or less a brain dead. So sorry. here you are. So delic densities, etc. And you can see the sharpener. This is the sort of